that we have, whatever works best. So, all right, I have that we have about 4 minutes, so hang tight and we will get started in a moment. Kathy Sarnes, I'm going to go ahead, and I know you are on the phone, so I am going to type you in for attending today via phone. And Alicia, I see you too. I believe. Are you on phone, Alicia, or are you on a computer and just don't have a camera? Hey, Tony. Oh, does it ask for one? Shouldn't, but okay. No, it shouldn't. It shouldn't be. Let me just send you the whole new one, just in case. Okay? Yeah. Bye. Hope everyone is able to get on okay. I have several people requesting. Okay, here we go. All right, thank you everyone who has hopped on this morning. Happy Monday morning. If you could, please put your name and your location into the chat box. This will be our way of keeping attendance. Not that you're required to, it's just that for purposes of being able to do the recordings, it just is great to be able to show how many we have online. If you have multiple people with you, be sure to add their names as well, who might be sitting in with you. All right, we'll give it one more minute, so much appreciated. Meanwhile, if you think of any questions that you have, certainly you're welcome to put them into the chat box at any time, or feel free to unmute yourself and ask at any time. You don't have to wait till the end. Sometimes it's last minute and it's not as easy to get to your questions. So,
all part of your destiny. This is all destined to come your way. The wheel of fortune is shifting in your favor. So because of it, you don't like bad luck or like blockages in your life, things just not going the way that you want them to. This is things finally shifting in your favor. You know.
all right. One more minute. Thank you. Glad that you all could join us. If you've just hopped on this very minute, please do sign your name into chat. But if you're on the phone, unmute and let me know that you are. I'll add you to our list if you can. Kathy, I see Kathy Rogers. I see you are on phone, I believe.
I am.
Great. I'm glad you could join us. Been thinking about you lately. Hope you're hanging in there.
Things are much better
Are
recently. So
Good.
yes.
Yeah, if we could just keep it that way, that would be really good.
No, I agree, and I hope the same for you guys.
Yeah, we've been able to get to a few other things. So, all right. All right. Well, I have 12 after 2, so I'd like to bring this meeting to order. And thank you for hopping on at the last minute. Once again, just a reminder, if you just got on, that please do put your name in the chat box. And certainly if you have any questions, don't save them for the end. Feel free to put them in or unmute. So welcome today. I want to start out by a special welcome to our DHHS partners, and wondered if we have any new partners to introduce. I know that Robin said she could not be on today. Robin Williams.
I'm here, Karen.
Oh, you are. Maybe that was for another meeting. I apologize. So I'm glad you're here. You're my tie to the other partners. So I see Kristen online, and anybody else that needs introductions from DHHS? I think we have no changes in the last month, right?
Yeah, I think unless Sandra Dolan, who is our new lead epidemiologist, I don't know if she was introduced. I can't remember dates and times right now. So
yeah, I was on the last meeting. So
okay, good. Okay, just want to make sure. All right.
But for those who weren't on the last meeting, we welcome Sandra to our gang and appreciate you being here. So we even have a spot for you on the agenda if you have any good words for us. So, all right. And I don't think we have anybody new at NPHHS or NPHL, excuse me. It's Monday. Emily, do we have anybody we should be adding now? At least to the CT side?
We will following next month. We'll bring in Greg on the CT side.
Okay, awesome. That's perfect. So we'll get started, and just want a quick report from any EPI people that are with us. I constantly have on the reminder on every agenda that obviously if you're going to need any testing, even some NPHL testing requires approval, but if it's certainly something that NPHL needs to send on to the CDC, we do have to have approval, and they're getting more and more sticky about it. So please do give us a call. You can page us, right, Emily? You can call any of us and ask, and we will walk you through the process. You don't have to know automatically what that paperwork might include. Do remind your physicians too, if they have a very unusual request, that they should probably get a hold of the local health department or even the EPI folks at the state. We usually like to start with the locals first though. All right. So I know, sad to say, we did lose one of our EPIs. Sadie is no longer with us, and I don't know if anybody else is on for any of the foodborne testing.
Brianna Locke is on from the Enteric program.
Brianna. Great. Thank you. Any words of wisdom?
Um, not really, no. Just, yeah, Sadie's been gone for a week or so. So just,
Hey, Lindsay, how did Brett do at this track meet?
Oh, we did
A
good.
moment, I'll get that. All right. Go ahead, Brianna.
oh, okay. Yeah, so Sadie's gone from DHHS, so it's just myself right now with the enteric program. I'll be working on training a couple people to help me out in the program. So, if you don't, especially this summer, because I will be out on maternity leave, so they're going to be my contact. So if you have a couple other people you're unfamiliar with that are reaching out, to the lab, and for example, a norovirus outbreak, and we're needing specimens sent to MPHL, don't be alarmed. I helped train them, and they're doing what they're supposed to. So I'll make maybe an announcement next month when we get them officially trained, so we know who will be helping out.
Okay. Sounds good. Well, let us know if there's anything we need to do to help you through this time until you get your assistants trained. So, okay, any other outbreaks that we need to know about? Robin, any comments on flu or RSV?
Flu is still going up, and it's circulating out there now, just because COVID kind of reduced, flu did not. Prevention measures have been reduced, therefore other respiratory diseases are going up. And there's that note there about the lab alert. So in relation to, high path or any other flu, if you get an unsubtypable on your respiratory panel, please contact us and forward those specimens onto the public health lab. We need to determine if it is indeed a novel influenza or not. So please contact us, contact the lab, and get those sent up there. Does anybody have questions about that? About seeing unsubtypables?
Robin, I know that we have had a few questions to clarify that untypable. So obviously the people who do that panel probably are the ones who would recognize this. However, those who maybe do regular PCR or the simple rapid test come up with a flu A, and that's it. It doesn't say necessarily untypable. So just know that no, you do not need to send every flu A in unless you're suspecting something unusual about it. Certainly call us if you have any questions, but it's for those who do the respiratory panel, the multi-platform methodology, that you will get the non-typable alert. And that's what we're really looking for.
Yeah, you should get an H1 or an H3. And if you do not get that, then send it on over. It will type out to be an A.
Robin, this is Brian. What are your thoughts on people that have known exposure to birds, and say they just have a rapid type A, but they aren't able to, get the confirmation that it's not an H3 or an H1?
If they have had a known exposure to a positive,
I'd like to see those all forwarded.
Yes.
Okay.
And yes. So if we get those, we can have specimen collection kits sent out as soon as possible if people know, or they can collect, but make sure to collect if they only are doing the rapid, and Emily, please help me out here, they have to collect an additional specimen if they have exposed, because you could you use one's collection for the rapid kit, and then if they do a PCR type of or molecular diagnostic, they can use that to send to the public health lab, but you'd have to collect another specimen if you're only doing a rapid diagnostic test. Was that correct?
You got it. If you're doing an antigen test initially, that swab is therefore spent for majority of the antigen tests that are out there. What we would need submitted for influenza surveillance testing for subtyping to identify a potential avian influenza in a human specimen would be a nasopharyngeal swab submitted in VTM.
Yep.
And
So-
Robin, I can share with you from the clinical laboratory's point of view, you know, they don't always know the patient history. So it's a great idea, Brian, but how is it that our laboratorians can come to know that information? We've talked about that before. I don't know if you can program that into your requisitions so you can see the patient's history, or just simply rely on a physician to share that information.
If a patient, this is a physician and a laboratory responsibility. The physician should be collecting that information if they know that the person is an employee at one of these poultry farms that are positive. If we're sending them in to get tested because we're monitoring them, we will be sure to tell the patient that they need to tell their physician that I have been exposed. I want tested. Providers should be aware that they should test these people. And then when you are ordering these flu tests, you have to do it through NewAlert, and it does ask if there is an agriculture exposure. I think it says agricultural. It might say swine. If it just says swine, put a comment in, or we'll fix that.
It.
Okay, swine or avian exposure, but it needs to be completed in NewAlert, and so we need that information. So hopefully everybody can work together to get that filled out.
Well,
Yeah.
Robin, I would add, sorry, Karen,
But
I don't know where that noise is coming from, but I would add that, you know, we'd be interested in people that have exposure to backyard flocks, if they maybe have animals that birds that die off, or people that have exposure to waterfowl and waterfowl in the wild, because waterfowl in the wild are carrying this particular H5N1 substantially right now. So it would be interesting to know how that question is worded in NewAlert, and it's quite possible that people could show up in a healthcare setting where they maybe haven't had interaction with us at public health trying to monitor them, or even with Department of Ag or USDA who would be involved with trying to get a diagnosis in birds. It's possible there could be people with backyard flocks who just have chickens that die and they don't even call anybody. Now, that's not the way agriculture wants it to happen, because they want to be able to test and confirm if it's truly high-path avian influenza. But by all means, I think it would be good for providers to have a heightened awareness of this and exposure to poultry or waterfowl.
And that may be our responsibility to get that more information out. But with the help of the laboratorians, maybe that message can also be relayed.
Yeah, and we've been pushing that kind of message to people that are like maybe buying chicks in farm stores. We've done some messaging there so that people might have backyard flocks. I do know that Dr. Donahue is going to be doing an interview. Was going to do an interview this morning with one of the local news stations. So I'm sure that he'll get that word out too. That it'll kind of be in the news too. So hopefully we'll be getting it from a lot of different fronts. Thank you.
Say, Robin, this is Pete. I want to switch the gears a little bit on influenza B. You've been reporting out a fair amount of influenza Bs over the last few weeks. Every one of those Bs has come from a rapid antigen test. I suspect they're false positives.
That's why
can
we
you-
need them sent in if
Right,
we
but they have
have.
to collect another sample to do it. And I'm just wondering if there's some type of message that could be put out there to have, because they're being treated, I assume. Some of them are being treated and probably don't need to be treated. Just, I don't know. I don't have an answer for you there, but I'm just saying is I think we're seeing a lot of false positive results for influenza B.
Right, and unfortunately, our surveillance can't, because of the time frame, you know, it can't really be used for clinical. And they have to make, the clinicians have to make the decision to treat based on what they get right there. But we
Can you get a message out though that say that we really need to have a follow-up sample run on those folks?
We can send a note out to our, well, out to all of you folks, that we would like to get some of those samples in.
Right, but unfortunately, most of those samples are going to be in the clinics.
Right.
It could be a rapid antigen test that's B positive.
Yeah, this is Christy Nickel out of Bryan. I was going to just share that that's where we identified a lot of those coming out of. We weren't having any Bs here out of the hospital, but one of our techs who oversees the clinic hospital or the clinic labs has said, oh, we've had tons of Bs. And I'm like, oh, no, you have not. And so I told them, start sending samples. And our micro, Christy saw them. She was like, those aren't ours. And I'm like, I know, but I don't think those are true. And I said, we need to get those sent in. And sure enough, they were all false positives. So highly question it if your clinics are reporting out positive Bs right now. And I think it's appropriate. And what I'm hearing from Dr. Iwin is that we send that in through our hospital labs if we need to.
Yes.
Yes.
Yep.
Definitely would like those. Thank you, Christy, for sharing that. That's probably true in several areas. You were aware enough to make it happen. So we appreciate
I'm not aware of any of the major labs doing PCR testing picking up Bs. I don't think your results show that either, Robin.
I think that one, I think they're using the Sophia in those sites, but I can verify that with one of our staff.
Yeah.
And those are the kinds of things we'd like to, notify CDC about as well. If we are seeing a whole bunch of false positives, and then they can take it up the chain to say, well, your test isn't doing so hot.
Yeah, I wanted to make sure the vendor was aware because we were seeing so many of them.
So we have received a handful of these in the lab for confirmation, none of which have actually confirmed out as influenza B, but the tests that was performed on them initially were Sophia, McKesson's, and quick views.
So kind of a combination of
antigen tests.
So it's not one antigen test that's the bad one. So
anyway, Robin, if you can get the message out there, that would be great.
We will try to do that.
All right. Thank you, everyone. Any other questions on flu?
Karen, this is Gerald.
Go ahead, Gerald. Hi.
On that then, so there's several of us, a lot of the labs have maybe 2 different methods, so we have that too. So what you're saying is that we can put out to our providers, because we have a multiplex, but we have it broke to where we can just report out the influenzas. And sometimes in the summertime, we try to tell them not to do the rapid because the chances of doing that. That way we only have to worry about collecting one specimen. We can run the influenza on one platform and the COVID or like a COVID on the other platform. But I guess in those cases, we could put an email to the doctor saying, if you had this exposure, run the Verogen influenza panel and not the rapid ID Now panel. So if that helps, then we will have the VTM and we will be able to pick up the subtype because it does subtype the 3 and the 1. So I guess if that's what you want us to do, we can do that to our providers and tell them to order that test.
I think that would be really helpful with those who would have those exposures.
Okay. No, we can do that. We can, because it's a different orderable for us. It's not one, they can either order the one or the other. So we'll just tell them if you have this exposure, the state recommends us ordering this. So we can pick up some of those. So, okay, very good. Thank you.
Thank you, Gerald. Any other questions? I did skip over SARS or COVID. Emily, any comments that you need to share?
Still here. We are continuing to see numbers going down, as I'm sure Robin can share. As for sequencing, we are still predominantly Omicron. So nothing new from last month's call.
Okay. I know that the B2 variant is widespread in Europe, and I think that they're scared it's going to make it over here. So that will be interesting, won't it?
We have seen a handful of them over the last quarter, I would say, but they are definitely not predominant strain at this point.
Right. Yeah, understandable.
And I did want to just give a quick note. I know that HHS and others have started to not collect negatives. We will continue to collect negatives until further notice, and we will have discussions further on down the road to when we will stop collecting negatives. But please continue to send COVID negatives in. So that's our official stance as of today.
Good to know. Okay.
Robin, do you mean negative reports in?
Yeah, lab results.
Okay, thank you.
Right. Any other questions? Does anybody have any comments about norovirus? Anything about arbovirus?
I can give just a brief update on noro.
Yeah.
Definitely still seeing it in the community. We're having suspect and confirmed norovirus outbreaks reported still to us and local health departments, various settings, long-term care, assisted living, that's our primary settings. And I mean, nationally too, we are we're about halfway there, what we would typically see pre-COVID. In terms of norovirus outbreaks being reported. So we are creeping back up to getting a little bit back to normal with the number of outbreaks reported, but not quite there yet. But yep, still investigating any suspect or confirmed outbreaks. If we reach out to the lab and say, hey, can you guys, whether it be the middleman to get norovirus specimens sent to MPHL, or if we already have a lab confirmed norovirus, we might ask you to forward that to the public health lab so we can do some additional testing on those outbreak samples.
Say, Brianna, this is Pete. Have you seen, is rotavirus reportable?
It is. I don't know if Allison's on the call. She is technically overseeing rotavirus.
Yep.
Okay.
Yep, I'm on.
There's a lot of cases of rotavirus out there right now.
Yeah, we've been made aware of 2 clusters in 2 different long-term care facilities, and those outbreaks are over now. So with rotavirus, we don't open investigations on every lab or investigate every lab. We only investigate if there is a cluster, like in a school or in a daycare or long-term care facility, something like that. So we can make, infection control recommendations.
Sure.
But yes, those are the only 2. I know other health departments have reported that they've seen an increase in rotavirus. Other than those long-term care facilities, nobody's really been able to link them to like a common place or a common exposure.
Okay. It's out there. We know that. That's for sure.
Yeah, for sure. Yep. And yep, definitely.
Thank you.
And I think a lot of what people are seeing too tend to be on a GI panel, comes back on a GI panel positive. So. Correct.
Which.
Yeah, I'm wondering if, with the GI panels, we're seeing more of it. And we really don't know what our baseline is, because in the past, most adults probably weren't tested for rotavirus.
True. Start a study there, Tim.
I'll
Tim,
get on that.
That's
on
a
it.
good point.
That's a good point. We never
Yes.
thought adults and rotavirus were the same connection. So I'm sure that's the reason why we're seeing so many cases.
I think we've seen it this year, haven't we, Pete?
We sure have.
Yeah. All right. Good to know. Any questions on those viruses? All right. Anything on leads you'd like to share, Sandra?
Not much today. As we touched on the last meeting that the blood lead reference value was reduced from 5 to 3.5 micrograms per deciliter. Just still new, so I'm still saying it. Also, I believe the Lead Care 2 recall ended, and they resumed distribution of the tests as of February 14th. So that's going on. That's about all I have today.
No, that's great. I was not aware. Pete, you might have been on the recall ending, so that's good news.
Sandra, and correct me if I'm wrong here, but I just want to point out that the recall that has just ended, those are the point of care devices that are not considered confirmatory. And so if you had an elevated blood level identified, you would still need to send in for confirmation, as mass spectrometry is the confirmatory method for those levels.
Yes. That's what I'm saying. Yes.
Good to know.
And we run that here at NPHL. So if you have a client or if you yourself perform it that has elevated blood lead levels on those point of care devices, please let us know and we can confirm that for you.
Thanks, Sandra. Ishrat or anybody want to speak to antimicrobial resistance? I am going to bring something that Emily just shared with me this morning, that apparently there's been a recent change to the M100. And those of you who do sensitivities, this might be good to know. Can you see the letter from the CLSI on your screen?
No, you still have the
agenda. So that means I have to share. But anyway, as I'm trying to get that done, the letter discusses trimethoprim sulfa, SXT. Apparently there's been a correction. So I'm sorry, I will. Emily, I don't know how you do it, 3 screens. I struggle. All right, here, I'm gonna do a new share and it's right here. Okay, so the letter that came out was from March 18th, and just that disc diffusion. And I know not many people do the Kirby Bauer anymore, but you can see that there has been a change. And I'm not aware of the reason why these changes happen, or if it's for accuracy, it says it's been corrected to the 16 millimeter greater than or equal to. So they must have just gotten their symbols switched. Yeah, that makes sense. So
Looks
any
like
questions?
Looks like a typo error that they have.
Yeah, that's what it appears to be. And probably people didn't even realize it. They just kind of overlooked that issue. So, all right. Any questions about resistance? Have we had much in the state recently? Not aware of it. Have we done any testing, Emily, recently?
Nothing that I can think of off the top of my head.
Okay, all right. Anything else
No
before I go
CPEs,
on?
Emily?
Pete?
Oh, I was going to say no CPEs, Emily. I don't think we've seen any.
No, we haven't had any identified recently.
Yeah.
The other thing you could touch on in regards to that, Karen, would be the new suggestions for TB with the moxifloxacin.
Is that the TB?
Mm-hmm.
Yes. And so with that, I might ask Kristen, if you are on for TB and if you were aware of that change. Maybe she's offline at this point, but I did see her on earlier. So the, and Pete, go ahead if you'd like to add into that new recommendation.
Well, Kristen would be the one to talk about it. I guess she's not on, but there has been some discussion about using a 4-month regimen for treatment of TB, active TB, using moxifloxacin and some other drug. The issue has come up is susceptibility testing for moxifloxacin is not routinely done as a first-line test. So there is discussions nationally on whether they're going to include it as a first-line drug test. And I think that right now, if people want it done, we can request it from our testing site or our national program testing site. I don't know where it's going after the, what they're doing about it at the moment, but that's where it's at.
And I'll jump in, Dr. Iwan, I'm sorry.
Yes.
We haven't had any providers treat with the new regimen as it was just recently approved in the study 31. So we'll just do whatever temporarily. I'm guessing there will be some updates because every other program is facing the same issue. So luckily we don't have, we don't have a high incidence of TB in Nebraska, but it is obviously a very enticing regimen because it is 4 months versus the 6 to 9 months, which is the regimen we use right now. So that it is a big thing in the TB world that we're not only facing, but other states as well.
Yeah, I suspect that they're probably going to go to putting that as a first-line drug test in the future.
But the point is that it has to be specially ordered for now.
At the moment, yes.
So
there's a good MWR that was put out on this, and they specifically say it should be tested. But of course, we're not doing it routinely. So there you go.
Yeah. And we should know if someone is going to be treating with a 4-month regimen. I'm guessing the provider would let that, of course, we would know with the directly observed therapy that they would be doing that regimen. So we definitely will be on the lookout. And I will share this update with providers. I have not shared this since we just got this update last week, Dr. Iwan. But it will be something we'll be mindful of because not just, we have 3 TB consultants in the state, but obviously we have more than that treating TB in the state. So.
Perfect, Kristen.
All right, Kristen, thank you for hopping in there. So, all right. Any other comments from our laboratories? Okay. Before I go into, well, I don't want to skip MPHL client services. So, Brian and Paul, I think I saw you on. Do you have any concerns or anything you'd like to share?
This is Brian Lenz. There are no major issues right now to share that I'm aware of.
Okay. Tony, any issues you guys have been having?
Nope, we're good.
Okay. That's really good news. I hope your group has actually been able to take a breath too. So I know you've got lots of changes there, but I know you're training, so hopefully that works out. Okay. Before I go on into the chemical terrorism, I would like to just ask if anybody put thought to my comments last week. Bio safety tip of the month, that since we do have avian around, and if you are working with an untypable, not that you need to be concerned. I think the risks are very, very small. But in that light, if it were to happen that we had a human come positive, do you have anything in your protocol to beef up your precautions? And what would your laboratory do? Please feel free to put notes in chat or unmute.
We would call Karen.
Yeah, well, I think that we would be the first to put out a message to talk about BSL-3 precautions. What that means is that laboratorians working in a BSL-2 environment would add some precautions, just like we first did in COVID, where we highly recommended all mucus coverings, glasses, a good mask like a N95 or whatever will work for the laboratory. And also to be aware that you need to, disinfect every time you leave the biocontainment, and actually to work in the biocontainment or a biosafety cabinet or some sort of a setup, be it a face shield, a desk shield of any sort, to work with these organisms if that happens. So I want you guys to be aware of that. It's just something we do as preparations, or just to be safe. So be thinking about that and have it ready if it ever happens. So that's all I can add to that. And before I also get started with CT, any other new alert comments we need to add? Or have there been any recent changes we need to alert our laboratorians? Okay. All right, good to know. The reason I bring up chemical terrorism as I'm changing my screen again, it's not that we have a war going on in Ukraine. This is something that we've been talking about for a couple of years now. It is something we trained on a number of years ago. So what I want to do, where is my screen? Okay, so what I really want to do, I can't find my, okay, I don't see my sharing. Oops. Well, for heaven's sakes. Okay, so maybe I need to stop sharing and do a different share. All right, we'll do this. All right, now do you still see the agenda, or are you actually looking at my presentation? If anybody could help me out.
We're good.
What's that? Pardon?
We can see the presentation.
Okay, thank you. So we do have, starting about 7 to 8 years ago, maybe even longer, if you remember Josh Rowland, who was our first state training coordinator, literally did have started a program on chemical terrorism. He brought on about 15 to 18 laboratories who could be, say, prepared for shipping of specimens if this were ever to happen. And those laboratories may or may not have those particular supplies in their hands anymore. I will be contacting them to see if they do or not. But we had envisioned that if, you know, what we hope would never happen, if it truly did happen, that we had a plan in place, which we do. And so we talk about, you know, having that preparedness plan and the workflow of specimen collection, because it may be the same thing as, not necessarily as COVID, but that we might have to do some sort of mass collection. And therefore, this time it wouldn't be as easy as nasopharyngeal swabs, but it would be possibly urine and possibly blood as well. Urine is usually only needed when it comes to radiation exposures. However, for any chemical, they probably will want blood as well. So that's a whole new ball game. And people are not as likely to have the experience of drawing blood. The locations may not necessarily have plenty of bathrooms to collect all these specimens. So there's a lot to learn and things that will change if this is what needs to happen. And I always like to cite that there have been in past a few situations where specimens were collected. Everybody probably remembers the sarin exposure in the Tokyo subways. There's been others as well. And I'm not talking about collecting specimens of environmental. That is something that State Patrol might be able to do, or even better yet, our civil service teams would do, National Guard. But these are specimens on patients. You'll have patients coming into your hospitals. You'll have patients possibly even worried well who are not exhibiting symptoms, trying to block or trying to come into your emergency rooms or your clinics. So it's kind of an interesting situation with Tokyo back then. CDC was not prepared. I mean, they had over 5,500 specimens that were collected and needed to be tested. And back in 1995, they had zero capacity to do this kind of testing. And that was a real eye-opener to the CDC. And that required them to really put a plan in place. So through the years, they have worked hard to get other laboratories online. There are some some state health laboratories that can do all of the testing. There are laboratories, public health laboratories that can do some of the testing. And so if your public health laboratory and for you in Nebraska, we do some testing. So we're considered a level 2. Level 3 testing, there are a lot of states who are small and the only thing they can teach is specimen collection and specimen transport. Here in Nebraska, we can do some of that testing. I'd like to say that some of the testing we do usually falls in the nerve chemicals, the nerve reagents. But if we do not do it, then it would have to be sent to the CDC. So hence why we have asked a number of the laboratories across Nebraska, usually one in at least every coalition, not necessarily every health department, but every coalition, to handle all the shipping supplies it might take to ship to MPHL or to the CDC. So there are posters out that can be placed in your emergency rooms. These have been reprinted too. We had a campaign a number of years ago where these were sent out, and I think that the new ones will be doing some new sending of these to you as a laboratory, so that you can have a copy and then ask you to share with your emergency room. Of course, any testing done at the CDC is done by what we call the rapid tox screen. This has a special, I can't say a special permit, but it has been approved to be shipped as a category B. We've learned that in some of our classes with Pat Kane. And this type of testing at the CDC does include anything, including chemical, biological, nuclear, or radiological, any natural event too. It doesn't have to be terrorism with that too. And so the question really stands, can it happen in Nebraska? And one of our biggest arguments is that Nebraska has one of the largest railroad yards, of course, in North Platte. We also have the only coast-to-coast interstate that runs through Nebraska. We do see a lot of industrial chemicals that come through Nebraska, probably more than we'd ever like to know. So if there were to be an accident, and it would require permission from our state governor before we would ever have to collect specimens from humans. But if it were large enough, if it required it, you certainly would see the alerts from us, and we would be contacting those laboratories that do have those supplies. So I just wanted you guys to understand this process, even though you might not be one of those 18 laboratories, that this is in existence, so that you are aware that we trying to be prepared for any event. We do have enough supplies for 300. We will be beefing that up to 500 patients to be able to collect. And if we need to get those supplies out to you, we would be able to do it as fast as possible. Even if it requires us to carry it out, or if it requires a courier to be on a stat call to get that information, or to get those supplies to you. So if an agent is known, more than likely we would not have to collect specimens. They probably would know how to treat right there and then. However, I think our real scare comes with that unknown agent. And obviously, as I said, first responders will be the ones to do the environmental testing. But if it came to emergency room and hospitals being overwhelmed and requirements of specimen collection there, we will have a plan for you. So we kind of want you all to know what this plan is. If you ever go to our website at MPHL, I think most of you are used to the menu having BT preparedness. Well, there is a CT preparedness as well. And all those procedures will be found on that CT preparedness page. And so you'll hear more about this. We hope to share that training or those procedures with you on just-in-time basis. And we would possibly be doing some of this exercising in the future. I know in Omaha, we will be exercising a full-scale exercise here in May. And so hopefully we could possibly ask laboratories to even be a a part of that. So we're working on that now, and you probably will hear from us if we can work that in. These are some of the supplies we like to keep on hand, but if it's more than the 300 or 500 patients, obviously we have suppliers that have promised us to get more supplies, but if this tends to be a national event, obviously this would be too much for our state, and hopefully the CDC will take direction and lead us in what needs to be done. Maybe not necessarily the CDC, but it could be FDA, it could be FEMA, it could be any of the other partnering agencies that would assist us with that possibility. All right, there's a little bit of our stock. Obviously, this picture was taken long ago. We do have a plan where we would literally set up 9 stations. I'm happy to say after COVID, we learned a lot and have even made our CT side and radiological side to be more computer savvy as well. And so that's what we're going to be testing in May. We usually tend to have designated spots for this because it requires a lot of bathrooms. In Omaha, we have 3 sites that we have exercised before. If we were ever to go out to outstate, we might have to do that search for a location to do the specimen collection at last minute. So in our exercises, it's kind of fun because we are not necessarily drawing the people who volunteer to be players. We don't draw them directly. What we do is we have phlebotomy bands that literally fit around the elbow area, and you see that person holding up an IV line has red viscous liquid in it to resemble blood. And so our phlebotomists literally practice drawing blood from that phlebotomy arm. So it just makes it as real as possible in our exercise to collect both urine and blood. If it's a chemical event, that urine would require a clean catch, which adds, you know how clinics are, they it takes some explaining to patients in regards to that clean catch. So after our exercises, we always do what we call an after action report. We go through the things that worked out really well. We might have to also discuss the things that didn't go so well and think of alternate methods to take care of those issues and mitigate those problems. So, all right. So I just wanted to share once again that chemical terrorism site is right there in our left-hand corner. It will bring up for you a number of, I guess I don't have an image of it, but it will bring up the procedures you will need to know in collecting human specimens. And of course, we will be providing as much support as we can in this preparedness capacity. So thank you for sitting through that. I just want you all to be aware that this is what shall I say, a requirement of NPHL to practice this surge methodology. And we do try to do this from every couple of years. So, all right, I'm kind of flying through this. And so just wanted you guys to think outside the box and to think about it if it happens to be in your community, or heavens forbid, even come to your laboratory. So Any questions? If you have any questions about that, about those exercises, feel free to chime in or put it in chat. We'll leave it open. Has anybody exercised that before? I would like to hear of anybody who has literally exercised this process before, for chemical, not necessarily biological, but for chemical or radiological. If you have really good emergency coordinators, I suspect you might have. Or you just simply don't have time. Thank you. Post office in North Platte, a number of years ago, has, yes, and post offices, if you remember Amerithrax, back in 2001, post offices were required to do some testing of white powders, and they even have the instrumentation to do it now if necessary. So thank you for sharing that.
They're going to have
Anybody else? Thought I heard a voice there. All right. All right. Well, with that, I'm going to open the mic for any last minute questions. We only have 3 minutes. Is there something interesting going on in your laboratory that you question, need some help? Please let us know. I don't see anything in chat. I want to remind everyone that I am starting packaging and shipping this afternoon. I think it's closed now. You did have to register. I think I do have a class of 20 already. We try to limit it to that, so it's more interactive. But this will be held again in June. So look at your calendars. If you have had staff that have never been trained before, this is the class to take. Unfortunately, it is a full 8-hour class. I do divide it up into 2 days, so it's only 4 hours. That's grueling enough to sit through, and I do usually have hourly breaks with that. But we don't necessarily require this for those who have already taken this class. If you simply need recertification, contact me, because there is another site online that CDC provides that will allow you to get recertification. So be happy to share that with you too. It's a lot easier class, I can assure you that. So last call for questions. All right. Hearing none, I'm going to say, hey, thank you for joining us. And if you would prefer to ask a question offline, don't hesitate to give me a call or to email me. And I appreciate your time today. And so I hope you all have a great week. And thank you, DHS and MPHL, for sitting in today. Goodbye now.
Thanks, Karen.
Bill, those classes are here, June 22nd. Oh, don't know if you can see that. No, let me reshare that agenda, because it was on my agenda. I am going to have to get used to this. There we go. So share again. So those dates will be June 22nd. And this time the times have changed. Trying to, it won't be able to touch the second shifts, but day shift can be released obviously by their 3 o'clock time if they need to be picking up kids or anything like that. So yeah, we don't have the brochure out, but please save those dates if you can. Even just 1 or 2 people in your laboratory would be great. So the dates are 2 Wednesdays, and it would be the 15th. Oh, I said Monday, didn't I? I'm pretty sure that should have been Wednesday, the 15th, and then Wednesday, the 22nd. So I will get that brochure out as soon as possible. Okay, thank you all.